Hi, I'm Patricia Mangan. I'm a nurse practitioner at the University of Pennsylvania in Philadelphia here at JADPRO 2025. And just really excited with the Carvykti data that was presented. As patients are being treated with this chimeric T-cell receptor in multiple myeloma, it's indicated for patients with relapsed refractory myeloma who have had at least one prior line of treatment. And I think what was so exciting to see is that as patients with relapsed disease, moving Carvykti earlier in the treatment modality and lines of care have been so beneficial to our patients. But with that comes monitoring of potential toxicities and how best to coordinate with the referring providers and how best to get those patients from the referring providers to the certified treatment center. And so what I focused on was really discussion of those aspects of patient care. So I think the communication that is required, identifying patients early, and even earlier now that the treatment modality is moved as early as second line therapy is essential. So identifying those patients, getting them to the certified treatment center early has been helpful as we can start working on when timing is best for this patient. I think an essential part of this is really identifying and working closely with the referring providers in identifying the proper timing of this and preparing not only the patient, but identifying the care team support that patient will require to get through this process. I think that's a very important aspect. And we depend on the referring providers because they have manage that patient up to this point. They know the patient better than we do when we first meet these people. And so even though we will learn that, I think it is, we partner very closely with the referring team to really get a good sense of where the patient's at and how prepared they are, what education is needed. We don't take for granted that everyone knows the process involved in CAR-T, so we take that on ourselves as the certified center to really educate patient, caregiver, and support them through this because it is a stressful time for our patients. They're excited about this therapy, but I think knowing that there is support and educational materials that we can provide can be very helpful to our patients to successfully get through this process. Because the line of treatment has moved earlier, our hope is that patients will have less side effects from that. Their disease will be better controlled at the time of receiving Carvykti. As in earlier cases, it was after 4 lines of treatment. Not that patients didn't successfully get through that, but moving it earlier, we hope, has less potential toxicities or severity of the toxicity. I believe that patients, our hope is that they do better because their disease burden is less. We have a better opportunity to drive them into a better remission at the time of the infusion of CAR T cells. I think that's been helpful. I think the other new thing that has just recently come out is some adjusting of the REMS program where we now, where there was a requirement to have a patient being monitored daily for 2 weeks with staying close to the certified treatment center for 4 weeks. That's gotten adjusted a little bit where now daily observation is 7 days with staying close to the certified center has now moved to 2 weeks. That's helpful, but certainly if patients are having a toxicity or something, they will not be moving back to the referring facility. But if they're doing well, they can. The issue with that is the potential longer term toxicities that now is off-shifted a little earlier to outpatient facilities and referring facilities. So I think educating the community centers as well as outpatient nurses and providers when they're seeing patients, even at the certified treatment center, are seeing patients a little earlier, and some of the emerging side effects may not occur until they're out of the hospital or away from their daily observation period. So I think CRS, ICANS, or the neurotoxicities that are seen early in treatment are now being done, maybe managed and maybe observed even more closely as an outpatient. And that does put patients and their caregivers, now that some of the caregivers are the primary care observers of a subtle change in a potential toxicity that might be occurring a little later. I think educating them how best to notify our center that there's an issue developing, get them in quickly to be evaluated for this potential toxicity is an essential part of what we do as nurse practitioners and providers to educate them to safely get them through this procedure. So I think there has been a change in treatment structure of observation post-CAR-T, where there's a lot of completely APP-driven clinics that are monitoring our patients, seeing them in that daily fashion or very close to the treatment facility, or even once referred back to the referring community center, that APPs have a very strong role in this management. Understanding those delayed toxicities like neurotoxicities that can develop once home, it is an important aspect of APP management. It really has become pretty much solely driven by a lot of the APP-run clinics that we now are establishing to safely administer this agent.